Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. My name is Yazan Almasry, and this is my third PAL session. Yes, I'm keeping count. I really hope I could benefit you from this one. This topic, I guess you guys have taken it today. For those who are watching the recording, yani, whenever you've taken it, I don't know. Anyways, it's very heavy topic. I promise my best to make it as easy as possible. If you see that this recording is lengthy, you see it's longer than the actual lecture, don't be tempted to skip it because just it's long. Maybe it will be long, but I promise you, you'll leave the session understanding everything, inshallah. I will have checkpoint throughout the session. If you have any questions, it's preferable you save it to the checkpoint so that we can pause in the checkpoint and yani, we make the recording less. But if you have yani, a question and it's urgent so you can understand the concepts because the concepts are going to build upon itself, make sure to ask, okay? If I didn't see you in chat, you can also unmute, do whatever yani, you guys want. Anyways, like always, I like to clarify concepts before moving into what's it called? Any of the slides. Okay. So first of all, as you guys can see, this is the rib cage. Nothing difficult so far. Okay, so why am I showing you a rib cage? Okay, now what happens is that we have a heart behind the rib cage. Okay, and as a doctor, whenever we wanna examine or auscultate with this stethoscope, okay, why do we auscultate? Because we want to hear different valves of the heart, okay? I want to make sure that they're working well, okay? Now, you might think that, okay, for example, the heart is here, okay? When we auscultate, we're putting the stethoscope over this valve or this valve or this valve or this valve, but this is not the case, okay? We put the stethoscope at the point where the valve is heard loudest, okay? We don't put it here. We put it where the blood flow nears it, okay? You don't need to understand this. I'm just explaining so you guys get, like, for example, why the aortic valve is here instead of being here, for example, or why the pulmonic is here instead of being here, you know? It's flipped as well. Okay. Anyways, okay, I want to do this one simple exercise for you guys, okay? I want you to, there is a gap here. Can you see my camera? Can someone type in the chat if they can see the camera?
Yes.
Okay, perfect. There's this gap here. I want you all to put your finger here. This is this area, okay? And I want you to go down. The first bump you feel is this area. Okay? Do you guys feel it? Let me know in the chat. Yes, okay. Yes, okay, perfect. طيب. Now this area, why is it important? Because once we move to the right of it, we're here, okay? What is here? Here's the aortic valve. So in the clinic, this is how we locate it. We go here, we go the first bump, and we go to the right. This is the aortic valve, okay? If we go to the left of the bump, we have the pulmonary valve, okay? And you can feel like a gap. You can feel the rib and you can feel a gap, okay? And if you go a gap behind it, you're gonna have the third intercostal space, okay? So this is the second intercostal space. You're gonna have the third intercostal space, the fourth, and the fifth. Once you reach the fifth, okay, this is where we have the tricuspid valve, okay? Okay, and then this is where the tricuspid valve is in the fifth intercostal space near the sternum, okay? And then we have in the midclavicular line. So what's the midclavicular line? This is the clavicle. In the middle of it, if we go like in the middle of it, this is the middle, let's say, and we go in the fifth intercostal space, this is where we're gonna have the mitral valve, okay? Or the mitral valve sound, okay. So someone is asking, they have a question, okay. Thank you for teaching us, okay. You're welcome, okay. So again, the concept here is, okay, we have an aortic valve on the right, second intercostal space, so second intercostal space, and the pulmonic valve will be on the left, second intercostal space, okay, second intercostal space. The tricuspid valve, it's in the fifth intercostal space at the sternal border, and the mitral valve will be at the midclavicular line, fifth intercostal space, okay, or around the nipple area. That's how we find it in the clinic, and that's how we examine it. Okay, so now when we look here, okay, look, it says here, the right second intercostal space near the sternum, okay, and the left second intercostal space, we have the pulmonic valve, okay. In the left fifth intercostal space near the sternum, we have the tricuspid, and in the apex of the heart, or in other words, the apex of the heart is in the midclavicular line. Okay, so midclavicular line, left fifth intercostal space. And I'm sure you guys are going to take this in anatomy, in case you didn't. Okay, طيب. Why is this important? Okay, this is important so that when we examine either the heart sounds or the abnormality of the valve, we put the stethoscope over that area. Okay, so as a physician, when you go to the patient, okay, you will put your hand here, you will go, and then you'll find the second intercostal space and so on and so forth, and do the whole thing, and then you put the stethoscope over it. If you feel like there is abnormal sound, you'll hear it there. If you want to hear the normal sound, you'll also hear it there. Okay, طيب. Is this concept clear? I hope to see yes. Is clear, yes, okay. Yes, perfect, okay. طيب. Now the second concept. Okay. طيب. Do you guys know why does the heart sound happen or not? Just so I know if I want to spend so much time on it or not that much. I think Amar explained it yesterday.
Valve closure.
Okay. طيب. Valve closure. Okay. Now the interesting part, the valve closure does not produce a sound, it causes it. Okay. So what happens is that we have, this is the ventricle. Okay. We have blood here, it's filled with blood. Okay, right? So what happens is that when the valve closes, it's going to cause the vibration here. It's going to cause vibration. And this is the sound that we hear. Okay. طيب. We have 4 heart sounds. 2 are normal and 2 are abnormal. Okay. So what's S1 heart sound? S1 heart sound is basically when the atrioventricular valve closes. طيب. Now, when we say atrioventricular valve, it means the valve between the atrium and the ventricle. So simply the mitral valve, the tricuspid valve and the mitral valve. Okay, so when they close, they cause this sound. They don't produce it, they cause it. Okay, I don't think they're gonna ask you whether it's causes or produces. This is just for because it's interesting. Okay, but now the first S1 sound is caused by the closure of the atrioventricular valve. The S2 sound is caused by the closure of the aortic and the pulmonary valves. It's very simple, there's no rocket science in it. Okay, طيب. Someone is asking when we close the valves. Okay, did you guys study the lecture yesterday for Wigger's diagram or no? Should I explain this concept, how valve close? Does anyone know? Does anyone want to explain how valve close or no? Do you guys know? Okay, no one is answering, so I'll just explain it very quickly. Okay, it's very simple. Okay, so we have the atrium here and the ventricle here. Okay, and the way the valve close is just by physics, basically. Okay, the blood will flow this way, and it's gonna keep accumulating here. Okay, it's gonna increase the pressure here. Okay, so once the ventricle have a higher pressure than the atrium, it will push the leaflet this way and close the valve. So the whole point is when we have increase in the pressure, okay, so when the pressure of the ventricle is higher than the atrium, it will close the valve. When the pressure of the atrium is higher than the pressure of the ventricle, the valve will open. The same thing with the aorta and the ventricle. If the pressure is higher in the aorta than the ventricle, what will happen? The aortic valve will close. And the same thing will happen. Do you guys get the point?
Yes.
Okay, perfect. When the perfect. Someone answered. Shahad answered. Perfect. So this is what I'm trying to explain. Yesterday, I'm gonna explain this, so I'm not gonna go over it. Okay, so we have 2 heart sound. The normal, it's lub dub. Okay, and I'm gonna make you watch this video. It's very quick. I'm not gonna make you watch a long video. It's just 1 minute, just so you hear the heart sound and correlate what I just said. So just focus for the next minute. Is it working for you guys? I think it lagged.
When a healthy heart beats, it makes a
No, it's not.
lub dub sound. The first heart
It's working
sound,
now.
also known as S1,
Okay, perfect.
is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart murmurs or whooshing sounds produced by turbulent flow of blood. Murmurs are
Okay. So does that make sense? Heart sounds make sense? So we can actually get into the heart sound and each one. Yes, okay, perfect. طيب. Okay, طيب. So the first heart sound is S1 sound. Okay, so S1 sound, as I said, guys, it happens because of the closure of the AV valves. Where does it say? Okay, AV valve. We have 2 AV valves or atrioventricular valves. We have the mitral and the tricuspid valves. طيب. Where can it be heard? Obviously, over the mitral and the tricuspid areas. So what are the mitral and tricuspid area? I just mentioned them in the first slide. So can someone tell me? The AV valves. Okay, like I mean, when you auscultate them, on which area of the chest do we hear them? The mitral and the tricuspid valve. Second intercostal space left. No, that's for the aortic and the pulmonic valve. So I'll just go back to show it to you guys. So we're talking about the tricuspid and the mitral valve. Okay, the tricuspid valve is in the 5th intercostal space near the sternum. The mitral will be in the 5th intercostal space mid-clavicular line. Okay, this is where we hear the S1 sound. Okay, some of you guys are answering correct. For those who didn't answer, it's completely fine. عادي. And it takes time to get the concept. Once you go over the slides again, I'm sure you will. It's fine. طيب. Now, يعني الصراحة, let me be honest here for a second. We didn't take physiologic splitting. Maybe it's a complex or like an advanced concept, but I'm going to try to simplify it. And inshallah, you guys are going to understand it. Okay. So from the name, the splitting of S1 sound, what does it mean? Is that we have 2 valves, atrioventricular valves. We have the mitral valve, and the tricuspid valve, right? Do we have a heart here? Yes, we do. Okay, we have the tricuspid valve and we have the mitral valve. طيب. Now let's say for any reason, let's not think of a reason for now. For any reason, the mitral valve closes before the tricuspid valve. What will happen is that we're going to have an S1 sound here, okay? But this still doesn't produce S1 sound. So what happens is that once it closes, it's going to produce another S1 sound. So this is what's known as the S1 splitting. Okay, so we have 2 different S1. So we're going to hear S1 from the mitral valve. Then we're going to have S1 again from the tricuspid valve. Then we're going to hear S2. Okay. Don't overthink it. Just one valve closes before the other for any reason. Okay. It can be normal, which is physiologic, or it could be abnormal. طيب. Before I explain the pathologic, does it make sense, the splitting?
Yes.
Yes. Okay. Perfect. طيب. Now the pathologic is very interesting. Okay. I don't know if you need to know it. I'll explain it anyway, so you guys get the concept. Okay. It says. Okay. So let's read the sentence. It says if there is electrical conduction problems such as bundle branch block, you're gonna have splitting. Okay. طيب. Let's say the electricity or the action potential goes down and goes to the left ventricle. طيب. And since we have a conduction problem here, for example, it's not going to go to the right ventricle as fast. It's going to be slow. So what's going to happen is that this ventricle will contract and force this valve shut, while this ventricle is going to take a longer time. Okay, so what's going to happen is that this is going to close first, then this is going to close second. So we're going to have 2 S1s or splitting of S1. Does that make sense? Yes. Yeah. Yes, perfect. يعني it's not deep. Don't complicate it on yourself, and you're gonna get it correct, inshallah. طيب. Now the second heart sound, we have S2 sound. طيب. S2 sound is heard when we have the closure of the aortic and pulmonic valve. Okay. Pulmonic valves. It's written here. I don't know why I wrote it again. Anyways, طيب. Where do we hear it? Over the aortic and pulmonic areas. What are the aortic and pulmonic areas? I hope you get this time correct. And the right and left. Okay, perfect. Someone answered correct. خلاص. Alhamdulillah, you guys are getting it correct. Okay. طيب. I suggest you guys know this because it's a very simple question that you could miss, and it's really easy. You will know it straight up if you memorize it. خلاص. طيب. Now, again, we can have splitting of S2. Why could we have splitting of S2? Because the aortic valve, for example, closes before the pulmonic valve, or vice versa. طيب. This closure can be physiologic, or it could be pathologic. And I guess that's all you need to remember from this slide. And you just know that there is a second heart sound, which is caused by the closure of the aortic and the pulmonic valve. We could have splitting, okay? Why does the splitting happen? Because the aortic or the pulmonic valve happen, okay? And it can happen because of, for example, pathologic, it says because of conduction abnormalities. Just like I said, once it contracts, one contracts faster than the other, the valve will close differently at a different time, okay? It's very simple. Tamam, are we good? I'm just gonna check the time to see if I'm going too fast. Okay, no, I'm going well, I think.
Can you repeat?
طيب, which part do you want me to repeat?
S2.
S2. طيب, S2 is the heart sound that's produced by the closure. يعني the valve is like this. When it closes, it's going to cause the blood to become turbulent. And this is the sound that we hear. Okay? طيب. Now, S2 is caused by the closure of the aortic and the pulmonic valve. طيب. And just like in S1, we can have splitting of S2. What is splitting of S2? If we have, for example, I'll delete this, okay? If we have, for example, the aortic valve closes before the pulmonary valve, what's going to happen is that we're going to have S2 when the aortic valve closes at first, and then we're going to hear S2 again once the pulmonary valve closes again. Tamam? This is when we have splitting. And splitting can happen physiologically, which means it's normal process that happens by the body, or pathologically, which means in a disease state. Tamam?
Yes, thank you. Thank you.
Type. Someone is asking, what does not attenuated during respiration mean? They mentioned it a lot. Okay, so the doctor mentioned this, did he?
Yes, he did.
Okay, type. This is a concept, and I was planning not to explaining it because it's a complicated concept, but I guess now I have to. It's fine. We can explain it for you guys. طيب, yeah, let's get into this. طيب. Now, we have the heart. Oh, I need a heart. I don't know why I made an empty slide. Okay, we have the heart, right? Okay. We have the superior and the inferior vena cava, right? And they will all go into the atrium, the right atrium. Tamam? This is the normal, what happens. Now in sleep, what's gonna happen is that we have something that's called thoracic pressure, okay? Yani in the thoracic area, okay? Is the camera working well? Can you guys see me? Well, I'm just moving along.
We can see it working.
We
Okay.
can see you.
In the thoracic area, okay, what's going to happen is that, let's say you're sleeping. What happens when you're sleeping is that the thoracic pressure will be different, okay? It's going to be different when you're awake. Why does that matter to us? Because when this thoracic pressure is different, what is it going to do? It's going to squeeze this vessel and this vessel, okay? When it squeezes it, it causes the blood to go into the atrium. طيب? This is what happens during inspiration and during sleep. So when you inspire, you're forcing the blood into the heart. Okay? This is a concept that's also going to be explained in hemodynamics, I think. So don't overthink it, عادي. But look, it says a decrease of the intrathoracic pressure, the decrease in intrathoracic pressure, okay, it will force the blood into the atrium and increase the venous return. It means that it will increase the blood going from the veins into the atrium. طيب? It's just saying that. And this can cause, for example, the splitting of S2. You don't need to go into details. I'm pretty sure the question will be much more simple, inshallah. If not, I'm not sure. Dr. Simon didn't teach us. Know it just in case. But do you guys understand how it works, Yes, perfect. Okay. طيب. Now, then we have two other heart sounds. Okay. Now, listen to the sentence. This sentence is very important. S3 is sometimes pathologic, okay? S4 is always pathologic. طيب? Whenever you hear someone has S4, there is a problem. He has a disease. خلاص. point. Any point made, you know. If he has S3, it could be normal, it could be abnormal. طيب. Now let's discuss what's S3 and what's S4. Okay, so S3 is the sound of the ventricular filling. Ventricular filling. طيب. Now someone will ask me, Yazan, why do we not normally hear the ventricular filling? Because when we have normal ventricular filling, you're overfilling the heart, for example, so you don't hear turbulence, so you don't hear a sound. Simply, in normal situations, you don't hear the S3, but it could happen. But I'll talk about this in a bit. Okay, so the time we hear S3 in a pathologic situation is when we have overfilling of the heart. So once we have overfilling of the heart, the blood will become turbulent and you're going to start hearing the filling. And that's S3, okay? Because of ventricular filling. S4 happens because of atrial contraction. Now, normally, what happens is that the blood will go from the atrium into the ventricle. Okay, and then the atria will contract to force the blood in the ventricles. And normally we don't hear that sound. Okay, we don't hear that sound because there is no disease. Okay, but if the ventricle is thick and too thick, the atria will have to force the blood in, and it's gonna contract so hard that you can actually hear it. And this is the S4 sound. Okay, does that make sense, or should I repeat it one more time?
Can you repeat again?
طيب تمام. Okay, normally the atria, in the normal situation, the atrium contracts. Okay, contracts to force, to move the blood into the ventricle. Okay. Now, if the ventricle is thick or like stiff for any reason, we're gonna talk about any reasons, but I don't think you guys need to know it at this level. Okay. If it's stiff, the atria will have to force it, will have to contract so hard that you can actually hear that sound of contraction of atria, which is the S4 sound. Okay. Do you understand it, or?
Clear, doctor.
Okay. طيب تمام. الحمد لله. طيب, I can't see from the Zoom. Which slide are we on? I can't see the title of the slide from the Zoom thing. Is it the S3 sound?
Yes.
Okay.
Yes.
Okay, I'm sorry. طيب. So S3 sound, again, it could happen normally, or it can happen abnormally. Physiologic, whenever you see the word physiologic, it means normal. Okay. Whenever it's pathologic, it's abnormal. طيب. Physiologic S3 is heard in children or in trained athletes or thin people or pregnant women. Okay. Do you need to know who it happens in? I don't think so, but just in case, remember, pregnant lady, children, thin people, trained athletes. Okay, it's simple, and it's not that difficult. Okay, when do we hear the abnormal sound S3 or the pathologic S3? When we have overfilling of the ventricle. Okay, when we have too much blood entering into the ventricles, okay, you're gonna hear the sound of the filling, and this is abnormal. Okay, and does this happen in pathologic S3? طيب. So what this whole slide is trying to say is that S3 can either be normal, which happen in pregnant ladies, children, or trained athletes or thin people. Okay, or it could be abnormal when we have overfilling of the ventricle. طيب. And then here, it's saying here, it sounds like a diastolic gallop. It's just saying the sound. It's in English terms, gallop is like the sound of a horse. I think, I am not sure. My English isn't that good. طيب. When we say that it sounds like a proto-diastolic gallop rhythm, it's literally just saying what's the name of the sound. Okay, if we say like Ahmed sounds like a cow, literally you're just calling S3 as a proto-diastolic gallop. It's not something to understand. Okay, it's just the name of the sound. Okay, or the galloping horse. Okay, you don't have to know how it sounds. Just know maybe if the doctor mentions in the question a proto-diastolic gallop, he's referring to S3 or S4. I'm gonna get to that. طيب. Now, okay, so that's what it's saying. It has lower pitch and sound than S1. You don't need to know that. طيب. And lastly, the last point, it's heard best over the mitral valve area. Why? We don't know. We just know it's heard best around that area. Just know that S3, both S3 plus S4 They're heard over the mitral area, mitral valve area. Okay. Okay. Anyways, let's move on to S4. طيب. You guys understand S4? Why does it happen? Did you understand when I talked about the atrial contraction?
Yes.
That's literally all it's saying in this slide. Yani literally. Look, let's read it together just to make sure everything understand all the points. Okay, I mean everyone understand every point. Okay, طيب. So usually there is no physiologic cause of S4. So S4 is always a disease or abnormal. Okay, طيب. Now it coincides with the atrial contraction. Okay, and we explained why does it happen, because of low ventricular compliance. What does low ventricular compliance mean? It means that the valve is thick and stiff and it does not let blood in. Okay, that's another term. Yani, when we say low compliance, that means high stiffness, and we're going to get to that later. Okay, it has a gallop rhythm, the same sound, yani the galloping horse, and it's best heard over the valve, mitral valve area. There's nothing new here. I explained it all in a different slide. All the points are clear. Can we move on, or yes. Alhamdulillah, yani we're moving pretty quickly, and you guys are getting the concept, or I'm explaining too fast, so I'm still going. Anyways, so طيب. Now we have a checkpoint just to make sure. You guys studied the PV loops yesterday, صح? If you don't answer it, it's fine.
Yes.
If you don't answer it, it's fine. But yani, I put the question just to make it interesting. For those who don't answer it, it's completely fine. I was never the person who's always caught up, so don't worry. عادي. Go at your own pace and you'll catch up, inshallah. طيب. So the question says, when do you hear the second heart sound in the PV loop? Okay, so where do you hear the second sound? Does anyone know? See. No, it's not C. Let's see another answer. A. طيب.
Is it
A.
E?
Okay, so the answer is A. And honestly, I'm happy. Yeah, you guys, some of you are answering correct and some of you are not answering correct. Because in this lecture, I'm going to re-explain the PV loop. Because I want you guys to leave this lecture knowing everything about the PV loop. PV loop is so important. You're going to get a lot of questions about it, and I'm going to make sure everyone leaves knowing everything. I know Atas explained it yesterday. I'm just going to refresh the concept, inshallah. So the answer is A, okay? This is the area. I mean, yeah, the answer is A. This is where the aortic valve, or S2, is heard. Second heart sound refers to S2. طيب? And this is where the aortic valve is closed in the PV loop. Since yani, most of you still, I didn't review the what's it called, the PV loop concept, I'm just going to move on and then come back to this after I explain it. Okay? Do we agree?
Sounds good.
Okay, tamam. طيب. Okay, now we're going to talk about heart murmurs. Now, normally, we don't have murmurs in our heart. Okay, we just have S1, S2, sometimes S3, and that's it. Okay, what's a murmur? A murmur is an abnormal sound. Okay, why does a murmur happen? Okay, a murmur happen because the blood flow is turbulent. Okay, there is any turbulence in the flow of the blood. You guys know what the word turbulent mean, right? In first year, I didn't know what it meant. For those who don't know, don't be shy. Tell me, and I will explain it to you. It's basically, in other words, the blood is dancing, yani, all over the place. طيب. تمام. Now, this is what a murmur is. Okay, murmur. طيب. Now, we can have, okay, a murmur can be either systolic or diastolic, and it could happen because of stenosis or regurgitation. طيب. Now, let's take it from the beginning. What is systole? Systole is basically when the ventricles have blood here, okay, and they contract to push the blood out into the vessels. This is systole. طيب. Now, what's diastole? Diastole, when the ventricles are relaxed, and the blood is going into the ventricles and filling it. طيب. So, if we hear a sound during diastole, or during the relaxation of the heart, that's known as a diastolic murmur. If we hear a sound while the heart is contracting and pushing the blood out, that's known as a systolic murmur. تمام? Okay. So that's the first concept. And now I'm going to explain to you how to know whether it's diastolic or systolic. Okay, don't worry. طيب. The second concept is stenosis and regurgitation. Does anyone know what's stenosis and what's regurgitation? Or was it explained in another lecture or not? Not as a general information if you know it. Stenosis is stiffness, yes. Regurgitation. And the valves is stiff. Okay, okay. طيب. So regurgitation when it's going backflow of the blood. Okay, طيب. Okay, let me explain this. طيب. So stenosis. Oops. Stenosis is when the valve is stiff. طيب. Now, let's take a whole example about this. Let's say we have, for example, mitral valve stenosis. What does mitral valve stenosis mean? It means the mitral valve is stiff. So, during diastole, okay, when the heart is relaxing, the blood will go through the mitral valve, okay? Normally, when it goes through the mitral valve, it will just fill the heart and خلاص fill the heart and life is easy and that's it, okay? However, when the mitral valve is stiff, what's going to happen is that the blood is going to be so turbulent when it's trying to go through because it's squeezing its way through it. It's trying to go there and it's going to become turbulent and it's going to be so turbulent that it produces a sound. And this is what a murmur is caused. And since the blood goes through the stenosed valve or the mitral stenosed valve during diastole, it's known as a diastolic murmur. So when we say mitral valve stenosis, is it a systolic or a diastolic murmur? What's the answer? It's written in front of you, you guys. Please.
Diastolic.
Diastolic.
Diastolic. Okay, perfect. Do you understand why, or should I re-explain why? Yes, understood. Perfect. Now, again, we're still going to talk about the mitral valve. Let's say we have something called regurgitation. What is regurgitation? Regurgitation, I'll just write regurg. دبروا حالكم. Okay. So let's say in regurgitation, what happens is that the valve is so weak. Let's write it here. Weak. And does not fully close. Okay. I know you guys have been saying backflow, but that's not fully true. Just say it does not fully close. That's the main thing. The valve does not fully close. Why is this important? Okay. Normally, what happens is that in diastole, the blood will go here. It will fill the ventricle. Okay. And usually, when the ventricle is contracting, you should shut this valve. طيب. However, in regurgitation, the valve is weak. It does not fully close, so the blood will actually backflow. Not backflow, sorry. Some of the blood will backflow, yes, but also more blood will keep going throughout the systole. Okay, so even when during systole, blood will go from the atria to the ventricle. Okay, and we're going to talk about that later on. But my point is, during systole, blood will go over the the valve and it's going to cause a sound. Okay, so in mitral regurgitation, we have a systolic murmur. Why is it in systole? Because that's when we have it goes over the weak valve. Okay, the blood is going over the weak valve, whether it's going back or going from the atria to the ventricle. Okay, and this is just a simple example, or actually, it's not simple, to be honest. But do you guys understand it? The concept of systolic.
Can you repeat, please?
Okay, I'll repeat. Just give me 1 second. Is it considered S1 sound? No. Why would we consider it S1 sound? S1 sound is just a sound of closing. Okay. After S1, so the valve closed. Okay, tamam. And then we have S2 sound when the valve, the aortic valve closed. طيب. These just the closure of the valve. The murmur is a sound in between them. Okay, or after them. Okay, it's not the sound of S1 or S2. And I'm going to make you hear a sound, and you guys are going to see how interesting it is. And it's different. It's completely different. But yeah, I'll repeat. So in regurgitation, we said the valve is weak. This valve is weak. When the ventricle contracts, normally what does the ventricle do? The ventricle will contract so hard, it will force it shut. خلاص, no blood will go in, no blood will come out. طيب. What happens if we have a regurgitation or a weak mitral valve? Even when the ventricle is contracting, when it's supposed to shut, it's not going to shut, and more blood is going to keep coming in. So it's going to keep going to the ventricle, and it's going to fill the ventricle more, and the ventricle is going to be going to the pushing the blood into the aorta and pushing it back to the atria, and it's going to be a mess. So during systole, you're going to hear the murmur because there's going to be turbulence in the blood flow. Okay? Does that make sense? If it doesn't, it's okay. I can explain another time and another time. You guys, it's fine if this is a hard concept. First time I had to study it, it was very difficult for me. Yes, makes sense. Okay. If it doesn't make sense for one person, I'm going to repeat it. So let me know if it doesn't. عادي. It's clear. Perfect. طيب تمام. I guess we can move on. طيب الحمد لله. طيب. These are the heart murmurs. Okay. I know you guys in the slides there is no a list of them, and the doctor talks about them يعني in not very organized way. But I put them in a list here just so you know them. You can memorize them however you want. You can memorize, for example, the diastolic murmur are just these two, and the rest are systolic murmurs. But it's up to you. Okay. You can figure out on your own. If you have your heart diagram and you can hear, like, you can figure out, for example, let's say we have tricuspid stenosis. Is it systolic or diastolic? Can someone help me? Let's say the valve is thick, okay, and the blood is going here during diastole. It's going to have to become turbulent. So is it a systolic or diastolic murmur?
Diastolic.
Diastolic. Okay, so you don't even have to memorize them. You could just figure out on your own. But I just kept it there as a table. You want to memorize them, up to you. You want to understand them, up to you as well. I prefer understanding them so you can actually figure out on your own. طيب. Okay, now here it's saying the slide. I'm just going to read the slide just to keep up with the doctor to make sure we cover everything. Okay, abnormal blood flow occurring during the ventricular systole. Okay, obviously if we have abnormal blood flow, we're going to hear it in the stethoscope, and this is called a murmur. طيب. So here the doctor says S1, S2. طيب. So what he's trying to say is that you're going to hear the first heart sound, which is S1. Okay, then you're going to hear the murmur, and then you're going to hear the second heart sound. Why is that? It's very simple, because when is systole? Systole is after, okay, systole starts after the atrioventricular valve close. And when does it stop? It stops when the aortic and the pulmonic valve close. This is what systole is literally. So between them, we're going to have a murmur. Does that make sense? I hope it does. Yeah, it's not like a hard concept. طيب. And this is what a murmur sounds like. Okay, I want you guys to listen closely. If you can't hear a murmur, it's okay. As a third year, and if you can't identify whether it's systolic or diastolic, it's fine. But just hear how it sounds. It sounds abnormal. You can tell it's abnormal. Can you hear that? Did you guys hear that? And
Can you play it again?
oh, okay. So someone is saying no sound. Okay, I'll register. Did you hear that or no sound? It's fine if it's no sound. No sound. Okay, خلاص. Listen to the slide, but I'm not gonna act it out. I'll embarrass myself. So just listen to the slides, and you're gonna hear the murmur. Don't worry. Anyways, what it sounds like, you're gonna hear. You're literally, once you have the slides, I'm gonna send the slides over. You're gonna hear like abnormal sound. You're gonna tell, oh, this is abnormal. This is not the normal. Okay. طيب. Oh, okay. طيب. So the first example that the doctor gave is atrial septal defect, and this is going to cause a murmur. طيب. Now, from the beginning, I'm going to explain to you what's atrial septal defect so we can agree and understand it all together and have no problems with it. طيب. So what's atrial septal defect? Normally, we have right atrium, and left atrium. Between them, we have a septum. It does not let the blood flow from here or from to here. Okay. طيب. Now let's say we have something called atrial septal defect. What does it mean? It means this septum that's covering usually, that's blocking here usually, it's not gonna be here. So we're gonna have an opening between the right and left ventricle. طيب. Now, what happens after that? Okay, so what? We have an opening. So what? what's going to happen is that the blood is going to start mixing. It's going to go from the right ventricle to from the right atrium to the left atrium, and so on and so forth. Now, how do we know whether it goes from right atrium or to left atrium or otherwise? From left atrium to right atrium? It's simple, by physics. Type. Now, physics says if we have higher pressure in the left atrium than the right atrium, blood will like to move from the left atrium to the right atrium because it likes to move from area of high pressure to area of low pressure. Okay, and that's what we normally have. We have higher pressure. Sorry, just ignore this. We have higher pressure in the left atrium and lower pressure in the right atrium. So the blood, if we have atrial septal defect, what's going to happen is that the blood will go from the right atrium, from the left atrium to the right atrium. And since it goes to the right atrium, it's just going to go also to the right ventricle. Fine. Now, is this concept clear? So I can move on and explain that concept after. Yes. Okay, fine. Now, normally, what happens is that in normal heart, the blood will go from the right atrium to the right ventricle, and that's it. We don't get any blood from the left atrium into the right ventricle. Okay, so let's say normally the right ventricle will fill this much of blood. Fine. If you have a septal defect, it's going to go from the left atrium to the right atrium, and then from the right atrium to the left ventricle, and fill it even more. Fine. Once we have overfilling of the right ventricle, what's going to happen is that the ventricle, first of all, it's going to need more time to pump out this blood. Okay, and since it's going to need more time, it's going to need more time to pump out this blood into the pulmonary trunk. Okay, what's going to happen is that this valve will close after this valve. So what is this called? Remember, S2 splitting. So we're going to have something called S2 splitting. Tamam? You understand why, for example, in atrial septal defect, we have S2 splitting? Yes. Okay, perfect. طيب. So that's the first thing that's going to happen. And also, the second thing that we're going to have is that we're going to have overworking of the right ventricle. Okay, so look, it says the right ventricle will continue to be volume overloaded. طيب. Now, do we hear a murmur, okay, in a systole or a diastole? Can someone tell me? Can you repeat? Okay, طيب. Which concept do you want me to repeat? I'm fine with the repeating. Just tell me which concept, or if you want me to repeat from the beginning, I don't mind. Systolic, yes, okay. Yes, hello. Systole. We're going to come back whether it's systolic or diastolic, but let me repeat the concept. Atrial septal defect. Okay. طيب. طيب. Atrial septal defect. طيب. So let's go back from the beginning. We said we have a septal defect, or in other words, we have an opening between the right and the left atrium. And this normally doesn't happen, okay? So what's going to happen is that the blood is going to go from area of high pressure to low pressure. So it's going to go from left atrium to the right atrium. طيب. Once the blood is in the right atrium, normally, what happens if it's in the right atrium? It's just going to go back to the left, to the right ventricle. طيب. Now, let's say we have a normal heart, okay? The normal heart will go from the right atrium to the right ventricle, and that's it. We'll fill this much blood. If we have a septal defect, the blood from the left atrium will go to the right atrium, and then from right atrium to the left to the right ventricle, and this is gonna overfill it. طيب. So once we have this overfilling, okay, the right ventricle is not used to this. So what is it gonna do? It's gonna need more time to push this blood out into here. Okay, so it's gonna need more time, and the valve will close later. Okay, so this valve, the aortic valve, will close first. It's going to cause S2. And the pulmonary valve will also cause S2, but it's going to be splitted, okay, or splitting, the concept I explained before. طيب. Another thing that's going to happen is that since we have, as the blood is contracting, okay, not the blood contracting, sorry, as the ventricle is contracting, it's pushing too much blood against, in systole, okay? So since it's pushing too much blood in systole, it's going to cause a systolic murmur. Tamam? So this is why we have a systolic murmur, okay, because of the excess blood going through the pulmonary valve. The pulmonary valve will have more blood going through it, so it's going to produce a sound. It's going to become turbulent. طيب? So this is what the whole slide is saying. And also here it says the sound. We're going to have S1, we're going to have the murmur, and then we're going to have splitting of the S2. Is this clear? Yes. Okay. طيب. Moving on, we have ventricular septal defect. Just like we said in the atrial septal defect, we have an opening between the right and the left atrium. We can have an opening between the right and the left ventricle, and it's very common. Actually, it's much more common than you think. Anyways, طيب. So if we have an opening, what's going to happen? Again, blood likes to go from an area of high pressure to an area of low pressure. And do you guys know that the left ventricle is thicker than the right ventricle? I think you guys know this already. But the left ventricle is much thicker than the right ventricle. And I guess you've seen it in lab. Okay. And what does it mean when it's thicker? It means that it has higher pressure in that area. Okay. So that means the blood will go from the left ventricle to the right ventricle. Tamam? So this is the first concept. This is concept number 1. The blood will go, if we have a septal defect or ventricular septal defect, the blood will go from the from the left ventricle to the right ventricle. Okay? Tamam. Now, what's going to happen? Again, the blood is going to be overfilled in the right ventricle. Okay? And it's going to close later. This valve is going to close later. The second concept is that we're going to have S2 splitting. Tamam? That's the second concept. Now, the third concept, which is very, very interesting. I don't know if this doctor explained it or not, but it's in the slides and I'm going to explain it to you guys. Is something called Eisenmenger syndrome. Okay, so what is this syndrome? Is that now, just like our muscles, when we work our muscle, what's going to happen? The muscle is going to grow bigger. Heart is a muscle. Okay, so what is going to happen is that if you have too much blood going to the right ventricle will try to keep up, is going to overwork itself, and is going to become bigger. Okay. So that's the third concept. Now, the interesting part is that the right ventricle will keep getting bigger and bigger and bigger to the point that the pressure here in the right ventricle will become more than the pressure in the left ventricle. And the blood will actually start going the opposite way. And this is what Eisenmenger syndrome is. I know this is complicated, and I could repeat it again if you guys didn't get it. But I hope you got it from the first time. If not, it's okay. This is complicated. We took this in 3rd year. I don't know why
Please repeat again.
It's okay. We took this in 3rd year. I don't know why they're giving it already in 1st year, but see Allah, I'll explain it. No problem. So the first thing that we said is that, sorry. We have a ventricular septal defect, okay? And the blood, normally, in the normal heart, the left ventricle will have a higher pressure. Here, we're talking about pressure. The left ventricle will have a higher pressure than the right ventricle because it's thicker. It doesn't show it in the picture, but it is thicker. It's much thicker. So the blood will go this way. And since the blood is going from the left ventricle to the right ventricle, it's going to overfill the right ventricle. Okay. And it's going to overwork it. So the first thing that's going to happen is going to need more time to close the pulmonary valve. So we're going to have the splitting. That's the second concept, okay? Now, the third concept is that since it's overworking the right ventricle and the heart is a muscle, what's going to happen? This muscle is going to keep growing on the right ventricle, is going to keep growing bigger and bigger. So it's going to become bigger here to the point that it becomes bigger than the left ventricle. Once the right ventricle becomes bigger than the left ventricle, the blood will start moving the opposite way. Does that make sense?
Yes.
Okay. Tamam. If
Doctor,
it doesn't,
so
I'm
in
not
the
a doctor,
end,
but thank you.
what should I call you then?
Yazan.
Okay. Then in the end, would the right ventricle get larger than the left ventricle?
Yes, that's exactly what happens.
Yes, but then when the blood starts to move to the left ventricle again, does the
I think
get bigger as well?
I get what you're trying to say, but no,
Yeah.
خلاص. I think by that time the patient will be very ill and
Okay.
Yeah, don't over do it. No, خلاص.
Okay, thank you.
Okay, you're welcome. طيب. And again, since there's nothing to do with diastole here, the murmur is going to be systolic because this is all happening during systole. Tamam? I guess it's very easy to know that it's systolic here. طيب, does anyone have a problem that it's systolic, or should I explain why? Because literally all of this is happening during systole. Yeah? Okay, طيب. So we're gonna have something called holosystolic murmur. Do you need to know that it's called holosystolic? I guess it's not that. Can you explain why? Okay, sure, I'll explain why. But because during systole, you're gonna have too much blood here. And again, the same concept that I explained in the atrial septal defect. When too much blood is moving over the pulmonary valve, it's gonna produce a sound. Okay, this is a murmur. That's what a murmur is. Literally, that's it. There is no complicating in this. Because of the too much blood that's going to the right ventricle, and the blood is becoming turbulent because it's too much. Does that make sense? Yes, thank you. No problem. So holosystolic murmur, it means that the murmur normally, this is how we actually, in actual hospital, this is how this is S1 sound, and this is how like sound waves are, and then you have like no sound waves here, and then you have S2. Holosystolic means that it will be the same amount of sound throughout systole until it reaches the S2. You don't need to know this, but I'm just explaining. So if they say mid-systolic murmur, so for example, it would be like this, and then in the mid-systolic phase, it would have a murmur. Okay, just to explain to you guys. Does that make sense? You don't need to know this, but I'm explaining so you guys understand everything. Yes. Okay. Tamam. So that's what's the first sentence is trying to say. Okay, and when it says like right to left shunt and left to right shunt, it's just trying to say that the blood will move from the right to the left or left to right. That's it. Okay. So this can lead to reversal of the shunt, and I explained why we have reversal of the shunt from right to left, because the right ventricle is going to keep growing and it's going to become thicker than the left ventricle. Tamam? Splitting of the S2 sound because the pulmonary valve will be closed later, and I guess خلاص this is the whole concept. Does everyone understand what's ventricular septal defect going to cause, or? Yeah. Okay. تمام. Now we have diastolic murmur, and I explained already when does diastolic murmur happen. It is when we have abnormal blood flow during diastole. It's very simple. Now the second statement is important. Okay. When they say S1, okay, so when do we hear what's it called? Diastolic murmur during diastole. Okay, so systole usually happens between S1 and S2. So this is where we have systole. I'm gonna write S as in systole, not sound. Okay, and then we're gonna have S1, and then we're gonna have S2, and the cycle is gonna keep repeating. Okay, diastole is between S2 and S1. So when are we gonna hear the murmur? We're gonna have S1, for example, then S2. Then we're going to have murmur, S. Then we're going to have S1 again. Does that make sense? It's between S1 and S2. So it's a diastolic murmur. And it's nothing new, just like repeating and explaining what's the second statement. Yes, okay, it's clear. تمام. And this is another PV loop question. I'm not going to ask it until we finish that. Okay, here I have 10 minutes break. So if you guys need a break, I'll give you. If not, we can have questions here if you have any questions about any concepts. But do you guys need this 10 minutes break, or should I just move on? Questions are sent. It's fine, no problem. I'll pause the recording for a second, just so that resume. Okay. I hope you all are back. Okay. Now we're gonna start with a new concept. It's called concentric hypertrophy. Now, remember, guys. Remember, guys, when I said the heart is a muscle, and once you overwork this muscle, what's going to happen? It's going to grow bigger. صح ولا لا? Yes. Okay. تمام. This growing bigger is also known, or thicker, is known as hypertrophy. Now, we have two types of hypertrophy in the heart: concentric and eccentric. طيب. And why is it important to know whether it's concentric or eccentric? Because it's caused by different things, and we're going to hear different heart sound for each one. طيب. تمام. By the way, are you all here? I forgot to make sure because it was a break. Are you all here? Yes, yes, yes. Okay. طيب. تمام. Okay. Now, the difference between eccentric and concentric is that each one is caused by something else. طيب. Now, the first thing is concentric. Okay, concentric is due to increased afterload. Now, whenever we say afterload, what are we talking about? I guess someone explained this yesterday to you guys at TAS. So what's an afterload? Does anyone know, or should I explain it? No one is answering, so I guess I can explain it, no problem. The amount of force the heart has to overcome to pump. Perfect. That's exactly what it is. طيب. So, when do we have increased afterload? Let's say this is the left ventricle. تمام? And this is the aortic valve. If the aortic valve is stiffened, or in other words, stenosed, what's going to happen is that we're going to need too much force to push against it. Okay? And this is called, in other words, the fact that we need too much force is called increased afterload. Okay, so what's going to happen is that the heart is going to overwork itself. It's going to work and work and work and work. Okay, to overcome this. So what does it do? It becomes thicker. You can see here the thickness is becoming more, and we have more. The heart become more muscular. Okay, طيب. So why does this happen? It happens due to pressure overload. Okay, so we're having increased pressure. We have to have increased pressure to overcome this increased afterload. تمام? This is for concentric hypertrophy. طيب. Now, why do we have S4 sound? Remember what did I say about S4 sound? Okay. Does anyone remember why? Can someone explain? If you get this, I'm really happy. If you tell me why we have S4 sound in this case.
Increased atrial contraction.
Exactly, because the atrium has to push against more force, because the ventricle becomes thicker, so it becomes more stiff. Okay, and the atria has to push against that. Okay, so we have S4 sound. Okay, and this is in concentric. Okay, so in concentric hypertrophy, it happens due to pressure overload. Okay, in other words, increased afterload. Tamam? And the first statement is saying it's going to have unchanged or reduced chamber size. So this is the chamber size. Here it gets smaller. Okay, why is that? Because the valve is getting thicker in a concentric way. You don't need to know why is it concentric way or whatever. Just know that it's reducing the chamber size. Okay, but so that's for concentric hypertrophy. For eccentric hypertrophy, why does it happen? Okay, it happens due to volume overload. We're having too much volume. And remember, what did I say about too much volume or overfilling of the ventricle? We're going to hear the S3 sound. Tamam? So we're going to have the S3 sound. That's the first thing. And the second thing, due to volume overload, we're going to have hypertrophy. It's going to go thicker, okay, in an eccentric way. So what does it mean in an eccentric way? The heart will become, the heart chamber is going to become bigger. So eccentric happens due to the increased chamber diameter. We can have S3 sound because of overfilling of the ventricle, and it happens due to volume overload. Okay, and it says it occurs with mitral or aortic valve regurgitation. Why is that? Because if we have mitral regurgitation, for example, the blood is going to keep flowing from the atrium to the ventricle, and it's going to overfill the ventricle. The same thing with the aortic valve regurgitation. Tamam? طيب. Why is this important to know? Because in hypertrophy, okay, this is any extra information. You don't need to know this. Okay, in concentric hypertrophy, we're going to have decreased compliance. Okay, decreased compliance. What is compliance? Is the ability of the heart to fill. So we're going to have less blood here. Look, if we say we have this much blood here, when we have concentric hypertrophy, we're going to have much less blood. While the heart is stronger, it's going to have less blood in it, so it's going to push out less blood. So that's what happens in concentric hypertrophy. On the other hand, eccentric hypertrophy, while it's also getting thicker, the chamber is becoming bigger. And when it's bigger, it's contracting very weirdly. It does not push the blood as effectively. So of course we're gonna have more space, yeah. But the blood pushed out is gonna be less when compared to the normal heart. So in both cases, it's a bad thing. We don't want this. And okay, we're at first, it's okay. It's trying to help the body, to push out more blood. But at the end, both of them are a disease. Okay. Eccentric is due to volume overload, and concentric is due to pressure overload. You don't have to know that it's a bad thing. And why is it a bad thing? Why is it less in eccentric? Okay. In third year, we took this mnemonic, which is basically whenever we have an eccentric hypertrophy, the heart becomes flappy and dilated. Okay, so imagine the heart, if it's dilated, the muscle is going to be like flappy. It's not going to contract as good. Okay, just like in everything, if you have something that's more tied together, it's going to contract in a stronger manner. Okay, when it's flappy, it's going to contract in a like disorganized manner. It's not going to push as much blood. Okay, does that make sense? Okay, tamam. So that's literally what's concentric and eccentric hypertrophy is. Tamam. Is this clear, or should I re-explain any concepts? Clear. Tamam. طيب. Then we have something called compliance. Compliance is what? It's literally compliance. Wait, let me move this away. Okay. Okay. Compliance is basically how much is the how much is the heart filling? Okay, how much can the heart fill of blood? Okay. Excuse me. So if the heart has decreased compliance, okay, it means that its ability to fill with blood is less. Okay. Or in other words, it's stiffer. Okay. So here it says decreased compliance equals increased stiffness. So if the heart is more stiff, it's going to have less blood filling in it. And that's why we explained here. Okay. This is decreased compliance or stiffer heart. Okay. Now, if the heart has increased compliance, it's going to have decreased stiffness and reduced pressure. طيب. So in the beginning, this is going to be explained in hemodynamics. If you don't get this concept, it's okay. طيب. So compliance is equal to, let me remember this, volume over pressure. طيب. Why is it important to know this? Okay. Let's say the heart is very compliant. Okay. What does it mean? It means that we can fill more volume without changing the pressure of the heart. Okay. On the other hand, if the compliance is low, that means we can have less volume for the same amount of pressure. And this is exactly what they're explaining here. So let's say we have 120 milliliters here. If we have a normal heart, we're going to have, for example, 10 pressure. Okay. If we have decreased compliance, we're going to have 120 milliliters, but the pressure is going to be much higher. Okay, it's going to be like 30. If we have a compliant heart, it's going to become like 5. The pressure is going to become 5 for the same pressure because the heart is more accommodating for the blood that it's getting. And it's not changing that much in pressure because it's more compliant. Okay, does that make sense? This is going to be explained again in hemodynamics, but I'm just like trying to clarify the concept. So once you go into that lecture, you already understand. Clear? Yes. Tamam. طيب. Are you sure, guys? There's only one person responding now, which is fine. Yeah.
One more time, please.
One more time, no problem. Okay. طيب. So compliance is how much. Let me write this here. Okay. Compliance is accommodation. Accommodation of blood. So if the heart has high compliance, that means it can accommodate more blood without increasing the pressure. Okay, and it's gonna stretch with the blood, and it's gonna be more compliant. Okay, tamam. If the heart is stiff, it's not gonna be able to stretch. It's not gonna be very compliant. It's not gonna be able to accommodate as much blood. Tamam. So that's what we mean. If the compliance is high, the stiffness will be low. And also, if the compliance is high, we can have more volume without changing the pressure. طيب? And this is what it's showing here on the graph. If you have more compliance, you can have the same amount of volume without changing the pressure. Or if we were talking about the pressure, look, you can have more volume for the pressure. You can have 250 for the same pressure as the normal heart. طيب. I don't want to go too deep into that concept. It's going to be explained tomorrow, inshallah. For now, does that make sense?
Yes, it's clear now. Thank you.
طيب. No problem. So this graph, where does it come from? Or this line come from here. Excuse me. It comes from here. It's this line, this one. So it's just showing if we have less compliant heart, and this was explained yesterday, I guess, okay? If the heart is less compliant, we said we're gonna have increase in pressure and decrease in volume. In diastolic volume and diastolic pressure. Does that make sense? And this is how we apply it. He didn't put this in the slide. I'm just explaining so you guys make sense out of it. تمام? Is it good? Should I move on? Because now I'm going to review the PV loop. تمام. Okay, so for now, I'm going to be reviewing the PV loop. Yesterday, this was done. For those who are watching this recording, or for you guys who already attended yesterday and don't want to get bored, you can come back in like 10 to 15 minutes. I'm going to be done with this, inshallah, and then I'm going to move on to the next concept. But see, and you have to be perfect with this concept to be able to understand the changes in PV loop. Tamam? So if you don't get the PV loop that much, let me explain it to you, and I promise you, I will make sure you understand everything in it. Okay, tamam. So the first concept, what is PV loop? From its name, pressure against volume. Okay, so they took the pressure of a left ventricle, and it says LV here for the left ventricle. They took the pressure of the left ventricle and they plotted it against the left ventricle volume, and they put multiple points. And this is the structure that they got. This is the whole thing that they got. Tamam? طيب. And they correlated it with what's happening in the heart as it happens. Okay? طيب. So let's start from the beginning. So let's say when the mitral valve opens, here is where the mitral valve opens. طيب. So when the mitral valve opens, what's going to happen is that the blood is going to flow into the left ventricle, and the left ventricle is going to start filling. So what's going to happen to the volume? The volume is going to increase. Here we can see the volume increasing. Tamam? And it's going to increase to the point where the pressure is in the ventricle is higher in the atrium, and it shuts the mitral valve. طيب. And this is when the mitral valve closes. And again, when the atrioventricular valve closes, what do we have? We have the S1 sound. طيب. So that's the first part. Then, what's going to happen is that, as you guys know, the ventricles normally contract. Okay. So the ventricles are going to be contracting. Okay, but there is a point where, like, the ventricles, even though they're contracting, no blood is moving out. It's just the ventricle contracting, and since the blood is not moving out, the pressure is going to be increasing. Here we're talking about pressure. Look how the pressure is increasing. Here the volume was increasing. طيب, the pressure is going to become too great that it becomes higher than the pressure in aorta and opens the aortic valve, and the blood is going to move into the aorta. So once the blood is moving out of the ventricle, okay, since the blood is moving out of the ventricle, the volume is decreasing. Again, here's volume. To the point where the pressure in the aorta is higher than the pressure in the ventricle, so the aortic valve will close. And this is called the S2 sound, when the aortic and the pulmonary valve closes. طيب? Okay, what happens after that is that we have relaxation of the ventricle. Once the ventricle relaxes, the muscle is relaxing, the heart is becoming less dense, and we have less pressure. So the pressure is going down. Tamam? Doesn't it look like a loop? That's exactly what it is. It's a loop. Pressure volume loop. And this is pressure. Does that make sense? This is what, in the nutshell, the PV loop is. I know this is not my topic, but I'm making sure you guys understand this concept. Does it make sense? Yes or no? Or did you guys all go and you all understood the PV loop? I think maybe that happened. Yes, it makes sense. Thank you, Shahad. The most interactive person. You need a prize. Okay. Yeah, clear, perfect. So that's the first concept, number one. Now, the second concept is systole and diastole. So when does systole happen? When we have the beginning of the contraction. Okay, so the contraction here. So what happens here? Here is where the mitral valve closes. Okay, so once the mitral valve closes, the ventricle is going to start contracting. and it's gonna it's here, it's still contracting and pushing the blood out to this point. This is when the aortic valve closes. Tamam? Once the aortic valve closes, خلاص, it stops contracting. It starts relaxing. And this relaxation is known as diastole. So, can we say that this part is called systole and this part is called diastole? Yes, we can. So this is diastole, this part of the PV loop is diastole, and this part of the PV loop is the systole. Does that make sense? I'll just erase. Does that make sense? Yes, 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 yes.
Yes.
Okay, perfect. Tamam. And this is S1 sound. Why is this S1 sound? Because here is where the mitral valve closes, and here is S2 sound. Tamam? Because this is where the aortic valve closes. Tamam. طيب. Now, again, afterload. What is afterload? Afterload is the amount of force you have to overcome to push the blood out. And it's represented by this, yani how high the graph is, okay? So in whatever case we have a disease, for example, where we have too much afterload, sorry, okay, we have too much afterload, what's gonna happen is that the curve is gonna get higher. So it's gonna become like this. Okay, so this is increased afterload. So when we have increased afterload, it's gonna look like this. Tamam? If you have decreased afterload, the same thing is gonna happen. It's gonna go like this, and the curve is gonna look like this. Tamam? So this is for afterload. طيب. What is preload? Preload is the amount of blood or end diastolic volume. Preload, in other words, is end diastolic volume. End diastolic volume, if we dissect the word end diastolic, so at the end of diastole, how much blood we have? Okay, so yani, after the filling of the ventricles, how much blood do we have? This is called, in other words, end diastolic volume. Tamam. So if we have less blood for any reason in the after the end diastolic volume or after diastole, the graph is going to become like this. It's going to become smaller from here. طيب. What are some cases where we have less end diastolic volume? Let's say we have mitral valve stenosis, and we said in mitral valve stenosis we have less blood going out because the valve is stiff, right? So less blood going out, what's going to happen is that the ventricle is going to receive less blood, so we're going to have decreased preload. Tamam? This is how it works. طيب. So this is what's preload and afterload. And then we have stroke volume. طيب. So what's stroke volume? Stroke volume is, in the nutshell, it's the work of the heart. How much blood is being pumped out, okay? So this point is called end diastolic volume. And this point is called end systolic volume, or this point, the same thing. They're the same line. End systolic volume. What's end systolic volume? So after pushing out the blood, how much blood is still left in the ventricle? Okay, because ideally we still, ideally the heart pumps out all the blood, but that does not happen in reality. We still have some blood left. So this blood left is known as the end systolic volume. Okay. Okay, and you can guess, for example, if we have higher end systolic volume, that means the heart is not pushing as much. There is a problem in the heart. Okay, does that make sense?
Yes.
Okay, type. So stroke volume is equal to end diastolic volume minus end systolic volume. Oops, I messed up. 1 second. End diastolic volume minus end systolic volume. Type. In other words, it's literally how much blood is the heart pushing. So if after diastole, we have this like 200 millimeters, and after the heart, after heart systole, we have 100 millimeters in the ventricle. That means the heart pushed out 100 millimeters. Literally, that's it. Does that make sense? So that's what the stroke volume is. Yes. Okay. Tamam. Okay, and this is the preload and afterload. I was gonna explain on this graph, but I guess I explained it without. So you guys understand what's the afterload or preload, or should I re-explain it? It's fine if you didn't understand it, because I can re-explain it. Clear. Tamam, tamam. طيب. So sometimes we can have changes in the parameter, okay, of the PV loop. Okay, we can have change in the preload or afterload. Preload again. Okay, طيب. So preload is also this point, okay, which is called the end diastolic volume. So the preload, in other words, is the end diastolic volume. What's the end diastolic volume? Is how much blood we have in the left ventricle. So if you have this much blood, 200 in diastolic volume, that's the preload. If we have more blood, then we have more preload. That's literally it, okay? Someone might ask me, how are we going to have more blood? It can be either because of more blood in the body, okay, that could happen. Or for example, the blood is going back from aorta because of aortic regurgitation. So you're going to have more blood, sorry. Oh, yeah. So let's say you have, for example, blood is going back here in regurgitation. What's going to happen? You're going to have more blood. So whenever you have more blood, in any case, you're going to have increased preload. Okay, we're going to talk about any different diseases in a bit. Fine. So we can have changes in the preload, changes in afterload, changes in contractility and compliance. Fine. Let's say we already explained the compliance, so I'm not going to go over it again. Fine. Let's say we have decreased changes in the preload. Okay, and again, we said preload is this point, okay, or yani end diastolic volume. Fine. So what's going to happen is that if we have a decreased preload, we're going to have decrease in diastolic volume, and that's what it says here. Okay. Now, if we have decrease in diastolic volume, if we substitute it in the stroke volume equation, we're going to have decrease in stroke volume. And we're also going to have slightly reduced ejection fraction. You don't need to know this. Just know these two first. Why do we have decrease in diastolic volume? Because that's what the preload is. And why do we have decreased stroke volume? Okay, so we have decreased stroke volume. Why? Because we have less blood in the heart to push out. So you're going to push out less blood, literally. Does that make sense?
Yes.
Yes.
Okay, so that's what we have decreased preload in. Fine. So let's talk about mitral stenosis. So in mitral stenosis, what do we have? We have a stenosed valve, okay? This valve is very stenosed. It does not let blood go through it, okay? So we have blood here. In diastole, normally the blood goes here freely وخلاص يعني مرتاح البلد. Literally imagine it this way. If the blood is going يعني is stenosed, the valve is stenosed, two things will happen. First of all, during diastole, the blood will be turbulent, so you're going to hear a murmur. The second thing is that the ventricle is not going to fill properly. So if it normally fills this much, in mitral stenosis, it's going to fill this much. And what's this called? This is the end diastolic volume. So we're going to have decreased end diastolic volume. And also we're going to have decreased stroke volume. Type. So in other words, in mitral stenosis, what are we going to have? We're going to have decreased preload. And literally this graph is the same as this graph, except the amount of preload that's decreased. طيب? So that's the problem in mitral stenosis. Does that make sense?
Yes.
Yes.
Perfect. Okay. طيب. And which type of murmur do we have in mitral stenosis? You're welcome if you don't get this.
Diastolic.
Diastolic, alhamdulillah, alhamdulillah. If you didn't get why it's diastolic, it's fine. I'll explain it one more time. يعني بس خلاص يعني تطلعوا من الليكتشر فاهمين كل شيء إن شاء الله. طيب. So, why is it diastolic? Because the murmur is happening only when there is turbulent blood flow. طيب. Let's take this case. We have mitral stenosis. The valve is thick. When does the blood go through this valve? During diastole. When it's going from the atrium to the ventricle, this is diastole, it's going to hit the stiffened valve and produce a sound. And it's going to become turbulent and produce a sound. That's why it's a diastolic murmur. Diastolic murmur. Okay. طيب. Now let's talk about afterload. Okay, remember in afterload, I said it's going to increase. It's going to increase, like afterload is represented by how high the graph is. So if it's this high, if it's any higher, that means we have increased afterload. What does increased afterload mean? It means we have to have more force to push against. Okay, so we have to overcome more force. Okay, that means there is either a valve that's thick, aortic valve stenosis, for example, and we have to push against it, or for example the heart is becoming stiff, or whatever it is. So what's going to happen is that we're going to have increased systolic volume, end systolic volume. Why do we have increased end systolic volume? Because the heart is here. Let's go to a heart. طيب. Let's say I'm going to go to different slides so I don't confuse you. Let's say here we're pushing out that we have this much blood. Normally in this heart we have this much blood after diastole. This is the end diastolic volume, صح? End diastolic volume. Now when the heart contracts, it tries to push as much blood as possible through the aortic valve into the aorta. طيب? And we're going to have only like this much blood left. Okay, so forget about this. Okay, we're gonna have this much blood left after contraction. So the blood left after contraction is, in other words, called end systolic volume. تمام? طيب. So let's say the heart has an aortic stenosis, or the valve is so thick that even when the ventricle contracts and tries to push it through, it will have like it starts with this much volume. It will have only this much. It will push only this much. Okay, and this much volume will be left. Okay, so what does that mean? It means the end systolic volume is going to be increased. Okay, so we're pushing less volume. Okay, so this is the amount that we're pushing here in aortic stenosis, and this is what happens normally. This is the amount of blood we push in normal patient. Okay, so can you tell this amount of blood that's being pushed out? In other words, it's called what? It's called the stroke volume. So we're also going to have decreased stroke volume. I think. I didn't look at the side, and I think that's what's going to happen. Okay, yeah, exactly. We're going to have decreased stroke volume and decreased ejection fraction. Do you guys understand why, or should I explain? Again, Yani. Understood, clear. طيب. And this is exactly what happens here. Oh, okay. طيب. In aortic stenosis. So in aortic stenosis, what happens is that the valve is thick and we have to push against more force. So the afterload is increased. Okay? And this is the graph that it's literally the same exact graph. And nothing changed. Tamam? And we're going to have increased end systolic volume, decreased stroke volume, and decreased ejection fraction. I'm not going to explain again because I already explained what happens in aortic stenosis. Do you guys get that? طيب.
Yes.
The question of the century is aortic stenosis a systolic or diastolic murmur?
It's systolic.
Systolic.
Systolic. Alhamdulillah. I'm so happy. Thank you guys. Thank you. Alhamdulillah. Why is it systolic? Because the blood during systole moves over the valve. Okay? Tamam? Simply as that, yani. And since the valve is thick, it's going to produce a sound. Tamam. By the way, you guys, if you have doubt about whether it's systolic or diastolic murmur and you need better explanation, tell me so I can explain at the end of the lecture again. Tamam? طيب. Are we good with this concept, or should I repeat anything? I guess we're good. Okay, yalla. Let's move on. 2 more. You guys, yalla, push through. We got this. Okay, now we have mitral regurgitation. Oh my God, what is this? The curve looks funny. And yes, it looks funny and it looks different, but I'll explain why. طيب. What happens in mitral regurgitation? This is the mitral valve. Okay, and we said in regurgitation, it does not fully close. Remember this term, fully close. It does not do that. طيب. So during systole, the blood will, during systole, what's going to happen is that normally, in a normal heart, the mitral valve will close. وخلاص, it will not let any more blood go in. طيب. And this is systole. Remember when I said this is systole? Are you good? Okay. I'm sorry, guys.
Isovolumic contraction.
Oh, yes. Okay, طيب. Let me explain this concept again, just to make sure everyone gets it. I forgot to explain it. I'm sorry, guys. طيب. From here. طيب. So here, again, what did we say here is happening? We said here, we're going to have filling. Okay, so this is filling phase. We're going to have increase in volume. Okay, because the mitral valve opens here and it closes here. طيب. طيب. Now, once the mitral valve closes, okay, the ventricle will contract but it will not let any blood out, even though it's contracting, okay? To this point. طيب. What is this called? This is called isovolemic contraction. طيب. Now, once the valve open, it's going to let all the blood out into the aorta. Not all, yani most of the blood out into the aorta until the aortic valve close. Now, once the aortic valve close, the heart will relax, okay? But the blood is not entering, okay? So what do we call this? Isovolemic relaxation. Why do we call it isovolemic relaxation and isovolemic, what's it called, contraction? Because the word iso means the same. So the blood is not changing volume and the heart is not changing volume. So the same amount of blood is staying when we have contraction and the same amount of blood is staying when we have relaxation. So this is the phase called isovolemic relaxation and isovolemic contraction. Okay, does that make sense? You guys, this is a very, very important concept, the isovolemic relaxation and isovolemic contraction.
Yes, makes sense.
Makes sense. تمام. طيب. Okay. طيب. So now, since the mitral regurgitation, let's go back to the mitral valve. The mitral valve does not fully close. Okay, and we said that normally what will happen is that once the ventricle contracts, okay, it will start contracting. Okay, and we're going to have this isovolemic contraction phase. Okay, where the ventricle is contracting and no blood is entering or leaving the valve, the ventricle. Sorry. Okay. This is what happens in normal hearts. In regurgitation, what's going to happen is that the valve is going to stay open. It's not going to fully close. And even while the ventricle is contracting, okay, and the aortic valve is still not open, the atria is bringing more blood. So you can see during this isovolemic contraction phase, it's disrupted. خلاص, you don't have isovolemic contraction. You're getting volume increase and increase, even though, what's it called? Even though what's it called, the aortic valve is closed and the only way you can get is from the atria, but the mitral regurgitation, the valve does not fully close, so the blood will keep flowing even if it's in during what's it called, during systole. Yes. طيب. Now you will tell me, okay, Yazan, why doesn't the blood just keep going and خلاص, you don't have any more blood and it just goes this way and the curve will look this way? Because as the ventricle is contracting, you can see the volume also is decreasing. It's not going into the aorta, no. It's going back into the atrium. That's why it's going this way. That's why it looks this way. So here, it's going from it's supposed to have the closure of the, what's it called, mitral valve here, but it does not fully close, so more blood will fill in, okay? And as it's contracting, it's pushing blood out of the ventricle back into the atria, because it makes sense. The valve is not closed, so it will just go back here. And when the aortic valve open, it's going to push it into the aorta and the normal curve will be back. Does that make sense? I know this is a little bit complicated, but does that make sense?
Yes.
Alhamdulillah. If it doesn't, it's okay. I can explain again. Can you repeat? Okay, perfect. I like repeating. طيب. So let's take it from the beginning. Okay. The heart is not fully closing. I mean, the mitral valve is not fully closing, right? So what's going to happen is that خلاص الهارت تعبى in the ventricle تعبى. طيب. And supposedly, normally what happens, the valve will close. However, it does not fully close, so blood will keep leaking and it's going to fill more and more. More blood is going to fill. More blood is going to fill. Okay, so you can see the graph is going to keep going this way, because this way, and it means it's increasing in volume. Okay, so volume is going to be increasing. Okay, even though it's, at this point we supposedly closed the mitral valve, but since we have regurgitation, it's not fully closed. Okay, طيب. Now in this phase, normally we have isovolemic contraction in this part. Okay, but in isovolemic contraction, we have contraction of the heart, no change in the volume, okay? However, here we have change in the volume. What's the change that's happening is that the heart is contracting, okay? It's contracting, the pressure is increasing. تمام? Normally, it would increase the pressure to the point the aorta, the aortic valve open and the blood will go this way. However, even before that, the volume will change. How does it change? Because when the ventricle contract, by mistake, since the valve is not fully closed, it will push it back into the atria. So you're going to have decrease in the volume as you go up this curve, okay? To the point where the aortic valve open. Once the aortic valve open, you're going to push the blood here. okay, and the normal thing is going to continue. طيب, does that make sense? If it doesn't, I can explain again. It's okay, or I can find another way to explain it.
Doctor, so what's happening is even though the volume is not supposed to change during isovolumetric contraction, the volume is decreasing because of the defected valve.
Yeah, we don't say it's decreasing. Look, the only thing we said here is the isovolemic contraction. Oh, sorry. The isovolemic contraction is disrupted. Why? Because at first, it's increasing more than normal. Why? Because any blood, even though diastole is done, the blood will still come in.
There's more filling, yeah.
Yes. And then, even though here it's supposed to go up like this way, but no, it will go back into the atria, so it will also decrease. So, the blood is decreasing and increasing at the same time. So we don't say it's decreasing or increasing. We just say we have disruption of isovolemic contraction. Do you get that?
Yes.
Does this make two valve open during contraction? Oh yeah, regurgitation. Yes, in contraction the valve will open because it's so weak. It's gonna open during contraction, and the blood will flow back into the atria. Does that make sense? Clear, thanks. Are you sure? I don't mind explaining again, but I do mind if you don't get it. I did. Okay, perfect. Can you explain again? Yay. Okay, I'll explain again. So I'll erase all of this. Here. I'll begin in a normal heart, okay? Focus with me. This is what happens in a normal heart. In a normal heart, this is where the mitral valve close. خلاص, the mitral valve close. تمام. And the ventricle will contract to the point where it tries to bring the ventricle pressure higher, like the pressure of the ventricle higher than the aortic pressure. تمام. Why does it try to do that? To open the aortic valve. طيب. Then the blood will go this way. Now, this is normally what happens, and the blood will go this way, so we're going to have a phase where the blood does not move. طيب? Okay, now let's say the mitral valve does not close. When the heart is trying to open the aortic valve, okay, first of all, even when the heart is contracting, the blood will leak out, okay, from the atria into the ventricle, so it's going to increase the volume here, okay? And when the heart is contracting, trying to opening the aortic valve, by mistake, it's going to push some of that blood back into the heart. This is why, look here, the volume is increasing. And here the volume is decreasing again. It's decreasing again. The volume is decreasing because it's pushing it back to the atrium. To this point where the aortic valve open, once the aortic valve open, I'm not telling you it will not go back to the atria at this point. Some of it will go back to the atria, but most of it will go through the aorta. And خلاص, back into the body. تمام? Does that make sense? Someone is saying, so we will have end systolic volume. Not necessarily. We won't have end systolic volume higher. We can say we can have higher end diastolic volume. And I want you to tell me, why are we going to have more end diastolic volume? Because the valve is open and it's not closing well. Perfect. Okay, that's it. تمام. طيب. So that's for mitral regurgitation. Is mitral regurgitation clear? Can we move on to aortic?
Yes.
Okay, طيب. Aortic regurgitation. طيب. Aortic regurgitation, let's think of it the same way we took it conceptually in mitral regurgitation. طيب. So let's say we have the heart here, normal. We're going to talk normal, then we're going to talk abnormal. This is the amount of blood, okay, in the heart. The mitral valve closed, okay. The heart is going to try to contract. It pushes the blood out, okay, and cool, and everything cool. The aortic valve opens, the blood is pushed out. طيب, after this point, in a normal heart, the aortic valve will close because the pressure in the aorta becomes higher than the pressure in the ventricle. And this is when the aortic valve closes. Once the aortic valve closed, خلاص, we don't have backflow. The blood is in the aorta. تمام? However, okay, and then we have يعني خلاص, the blood in the ventricle is gone, and then we have no blood moving into the ventricle, back into the ventricle. طيب. In aortic regurgitation, what's going to happen is that at this point, when we have the blood here in the aorta, it's going to start moving or leaking back into the ventricle. طيب. So what's going to happen is that after systole, okay, what's going to happen is that this blood is going to start leaking into the ventricle. And here, we start seeing, instead of having isovolumic relaxation where there's no blood going into the ventricle, we're going to have disruption of it, okay? طيب. So we're going to have blood going in, leaking into the ventricles, okay? So this is what happens. This is why the curve looks this way, because normally while the ventricle relaxes, normally there's no blood moving in. However, here, the blood is leaking and leaking and leaking, and we have increase in the volume. The same concept we had in mitral regurgitation, except this one, instead of isovolumic contraction, we have isovolumic relaxation. Does that make sense?
Yes.
تمام. طيب. If it doesn't make sense for one person, I'll repeat it. It's fine. Can you repeat? No problem. I can repeat. Yes. طيب. So we said, okay. So we said, normally in a normal heart, after the ventricle contracts and it pushes the blood into the aorta, what happens is that the aortic valve will close. Why does it close? To not let the blood backflow. In aortic regurgitation, what happens is that, again, we said it does not fully close. It does not do that. Okay, so the aortic valve, we're going to have, we're going to have blood here, and the aortic valve will be slightly open. So what's going to happen at this point, خلاص, يعني we push the blood into the aorta. طيب. Here, like this is the point, we're here, okay? طيب. Now, this part of the graph is when the blood is leaking from the aorta back into the ventricle. And you can see it leaking slowly, 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 slowly. The volume is increasing and the volume is going up. طيب. To this point where خلاص, يعني no more blood can leak out. Does that make sense? Okay, perfect. طيب, يلا. So this is his slides, and يعني, the same graphs that I explained. Some of his graphs looks different, but if you get the concept, you're gonna get it right. تمام? طيب. So what did we say here? Can someone tell me what is this? I mean, it literally says in the slides. No, don't tell me. خلاص. Okay. So this happens, okay, when we have increased afterload. When does increased afterload happen? Aortic stenosis. We already explained this. I'm not going to all go over this. And here he mentions it's a systolic murmur, and we explained why is it a systolic murmur. And he says there's increased in systolic volume. I think if you use my slides, it's easier to understand. His slides are good, but I think it's better if you want. It's more from boards and beyonds. It's really nice. طيب. Here, this point is important. We're going to have concentric hypertrophy. Remember when we said concentric hypertrophy, was it due to pressure or volume overload?
Pressure.
Pressure, exactly. So we're going to have pressure overload. Yes, I'm going to send the slide, don't worry. Pressure overload, okay? And it's going to cause concentric hypertrophy. And we're going to have S4 heart sound. Why do you think we're going to have S4 heart sound? Because of the concentric hypertrophy. We're going to have atrial contraction, which is going to produce the sound. تمام? It's gonna become a strong atrial contraction. طيب? Try to understand. Don't try to memorize. He's not going to ask you, well, what are you going to see in aortic stenosis? No, he's not going to do that. Don't worry. طيب. For mitral regurgitation, this is mitral regurgitation, I think, or stenosis. Sorry, mitral stenosis. Sorry, I'm confused. Okay, so in mitral stenosis, what's going to happen is that we're going to have decreased preload. Wait, I already explained all of this. Okay. Decreased afterload. I'm not sure why he put it here. It's not that important. These two are the most important statements. Focus on them. Decreased preload and decrease what's it called? Stroke volume. Okay, and you're gonna have a diastolic murmur. We already explained this. No abnormal heart sound. Okay, as in like not murmur, as in like S3 or S4, because S3 is due to abnormal filling, and that doesn't happen here, and S4 is due to atrial contraction. طيب. Now, in mitral stenosis, we're going to have something that's called atrial dilated hypertrophy. طيب. Again, why do we ever have hypertrophy? Because we're overworking a muscle. Now, in mitral stenosis, going back to mitral stenosis, okay. Since the valve is stenosed, what's going to happen is that it's not going to fully close. Since the valve is stenosed, it's going to fully close, and it's going to be very stiff to push the blood out. So we're going to have more than normal blood here. And then the atria, the atria is going to become larger in size. Tamam? So this is what's the point is mentioning. I have to finish this meeting quickly, so I'll try to finish as fast as possible. So that's what it's saying, atrial dilated hypertrophy. Tamam. And this is aortic, what is this? This is the aortic regurgitation, and I explained all of this already. And this is mitral regurgitation. I already explained this. I'm not going to go over it again. It's already pretty clear. Now this slide, it's literally just, I guess, recapping everything. Okay, if you want to study it, it's up to you. But what I would suggest is understanding everything, okay, and trying to put all the concept together, and then reading this slide, because this slide will be like a revision. Okay, everything already explained here, and it has already been explained. Okay, which brings me to the checkpoint. Okay, so what is this? Is this decreased preload, afterload, contractility? What is this? What's happening here?
Preload decreased.
Yeah, it's preload. So we have decreased preload here, as you can see it. I'm just going to draw it here. Then diastolic volume is decreased. You might be tempted to think it's decreased afterload. Yes, it's a little bit, yeah. But just focus on this. Okay. Which disease does have decreased preload?
Mitral stenosis.
Mitral stenosis. Okay. Tamam. Okay. Let's solve this question. This question is difficult, and it's not going to come, inshallah, but I want to see what's your thought process. So first of all, what do we have here? The blue one is the new one. Do we have increased afterload or preload? I want you to type in the chat.
What did you ask?
Is it increased preload or afterload? Okay, someone is saying is afterload. Okay, it's afterload. Okay, so is it aortic valve regurgitation? Do we have increased afterload in aortic valve regurgitation? Yes or no?
No.
No. Okay, no. Is it left heart failure? This is above your level. Forget heart failure. Is it mitral stenosis? Yes or no? No. Okay, no, it's not mitral stenosis. Pulmonary hypertension, also above your level. Don't worry about it. Is it systemic hypertension? Yes or no? Yes. Literally, I made it the only choice anyways. So why is it systemic hypertension? In systemic hypertension, what's going to happen is that the heart is going to become very stiff. Once the heart becomes stiff, think of it as a force to overcome. Okay, so once the heart becomes stiff, you have increased afterload, and this is basically going to lead to this curve. They're not going to ask you this. They're probably going to bring aortic stenosis. I just wanted to show you this, and just to test if you know this is increased afterload or not. Okay, tamam? And I promise you to go back to the question in the PV loop. I want to see if you guys understand or not. Can you guys answer this question? I'll give you 2 minutes. Let's see this. Someone answered E. Someone answered B. Okay. B. Okay. For that, who answered E? Can you explain to me why did you answer E? Someone answered D. Ya salam, ضيعتكم. Officially. Okay. Because it's diastolic phase. For that who's saying diastolic phase, I like your thinking. Didn't we say all of this is diastolic phase? Why didn't you choose, for example, A to B? and after S1 and S2. I get your point, but think of it logically. طيب. When does S3 happen? Tell me. You guys type in the chat.
S3 would be rapid ventricular filling, which happens after the valve opens.
طيب. At which point, A, B, C, D, does the mitral valve open?
A.
A.
A. طيب. So the rapid filling will be between A, where the mitral valve open, and B, where the mitral valve closing. So S3 is going to be heard at between point A and B. Okay? Does that make sense?
Yes.
Okay, perfect. Please repeat. طيب. So, what's the S3 or the third heart sound? It's when we have filling of the heart. It's the sound of the filling. Oh, what's this? Filling of the heart. تمام? طيب. In this PV loop, where does the mitral valve open? It opens at point A. Okay? Point A, the mitral valve open, and it will let the blood go into the ventricle and fill the ventricle. Okay? So this is increase in the volume because of the filling of the ventricle. طيب. So this segment of the graph is the filling of the ventricle. طيب. So S3 is going to be heard at this segment of the graph, which is between A and B. تمام? Yes, okay. طيب. I'm thinking, can I ask about S4 or not? Maybe I can't ask about S4 actually. Yeah, I can't ask about S4. طيب. طيب, can you guys answer this question? When does S2 happen? A. Wallah, I'm so happy, alhamdulillah. You guys, most of you got it wrong in the first time, and this time you got it all correct. Alhamdulillah. That means I explained well, or at least I'm lying to myself. One of the two. Okay. طيب. So this is all. That's it. Let me go to the end. Thank you guys for watching. For those who are watching the recording, I'm really sorry for repeating the concept over and over again. But repetition is important and it's key to understanding. So let me go to the last slide and I can stop the recording. So thank you guys for watching and bye-bye. Anyways.